I traveled to Fort Dodge, Iowa the other day to meet with Kari Prescott, Executive Director of Webster County Health Department, to learn about the practice of public health in rural Iowa. This 30-minute video provides an overview of the County Health Department in a simple discussion with Ms. Prescott about their services. Additional information is available in two documents that she sent me: their Community Health Needs Assessment and Planning document, which were provided just the other day. I hope that you'll enjoy witnessing a passion and commitment that she and her staff have, improving the health of people living in Webster County and in Iowa. If you would, please describe the Webster County Health Department.
So the Webster County Health Department is a government-based county health department, meaning we are governed by the Webster County Board of Health under the Webster County Board of Supervisors. The Board of Health has all jurisdictional controls salaries, controls activities, controls strategic planning, controls budget. For the health department, they make all the decisions. The only piece that the Board of Supervisors does is authorize our spending limits and authorize the revenue that is generated from our department.
So, could you describe, please, the services of Webster County Public Health in the context of national, state, and local?
We are grounded in the three foundational public policy development, assurance, and assessment. So very similar to the CDC, we operate under assessments. We do our community health needs assessment. We listen to or review county health ranking, any kind of information or indicators that come from the federal government that are specific to Webster County. If we can pull out that data, we compare that and try to have benchmarks and needles movement around those indicators. At a state level, when we write for particular grants, they give us indicators to follow. So for instance, our immunization grant would give us a benchmark around the national standard of 75% of our children need to be immunized, or 80%, or whatever that indicator is. From the federal government, they want the state to match, and therefore it gets handed down to the local level. Some of the same services as far as direct services, we are a home health certified Medicare Medicaid agency, so that is part of a small part of what we do within our agency. So similar to your larger organizations like Iowa Home Care and Unity Point and Gentiva, they have their home health department, but they are strictly home health. So they have the Medicare, Medicaid boxes that they have to follow, the conditions of participation. We also have those boxes and we follow those boxes, but we have this wonderful piece of our public health that is probably 80% of what the agency does, focusing around holistic assessments and population health. The services, we try not to get hung up on the services that we provide because we go in and figure out what the patient needs. So is it around social determinants of health? Is it around medication management? Is it around transportation or translation? Is it around homebound status? Is it around any other indicator, rent assistance? We really go in and do a holistic view and then try to figure out what pot of funding meets the criteria to assist the person. So if it's an immunization, we have immunization grant. So we can give them the immunization through the immunization grant, but then we're still addressing all this other stuff that's going on in the home.
Right. When you use the word population, who are your customers?
So our customers are the residents of Webster County. Primarily. So as we continue to receive contracts from the state, we've noticed that our local public health network, maybe we're not large enough in population to write for particular grants on their own. And so they needed to coordinate or collaborate with a neighboring public health agency to provide those services. So our board was very diligent to make sure that not only the people of Webster County, but be a good neighbor to help some of our other counties that maybe weren't big enough or had the workforce or capacity to write those larger grants, but definitely had the needs in those communities. So we're kind of that vessel for those local public health networks that surround us. So our primary focus obviously is our Webster County residents. However, like our maternal child health, we braid out into several counties to assure that those services are provided at a local level.
So what does this phrase population health mean to you?
It's making sure that the residents of Webster County, regardless of funding, regardless of ability to pay, regardless of whatever their barrier is, that we are that service provider to address whatever their need is.
So what does the phrase public health mean to you?
You know what? It is kind of interchangeable. So I associate the public, meaning we're a governmental entity. So our public status is that government funding, therefore we're a public entity and not a corporation or a private entity. We're a public entity. Therefore, we're in a public building. We follow public rules. That's what I associate public. Our board made a conscious decision, I think it was 9 years ago. There was always a negative connotation around Webster County public health. It was, everybody associated that we were only for people that really could not afford things in the community. So our board did a analysis to find out really what were the needs, and were we addressing needs of not only the people that there were several barriers, but also people that were more able to afford some of the care that we needed to provide or just needed a boost. And so at that time they changed us from the Webster County Public Health to the Webster County Health Department to really focus on that population health. Yeah, it was neat.
I'm going to shift gears just a little bit. What kind of data do you routinely collect?
So we collect data around infectious disease control, surveillance around food outbreaks. I'm going to forget some. We do lead surveillance, high lead in children. We just stuck our toes in the high lead for adults, trying to figure out some education around people that were having some high leads, adults that were having high lead readings. We track abandoned wells. We track arson in the wells. We will track flu surveillance. We're tracking, obviously, with Iowa Department of Public Health, mosquito, West Nile, any kind of disease outbreaks that might be in Webster County. We internally will track immunization rates for children, well child visits for children, smoking indicators for any population, BMI, A1C. There's several indicators that we track inside our walls. We weren't always able to have that raw data. Our board was very proactive here about 2 years ago to make sure that we had a electronic health record that provided us a holistic view of the person that presented for assistance at the health department.
Can you describe Can you describe your electronic health record?
So it is, it's called CHAMPS. Originally we were looking at another software company, but at that time this secondary company was not able to bundle our billing into the same software. It was more of a community-based connection where community resources could look at who was providing services. We needed something bigger and broader. We were spending a lot of time on putting the data into our own system and then into all the secondary requirements at the state level. So the state has their own databases that they want to track siloed information, and that wasn't good enough for us. We needed to have raw data, real-time data that we could pull immediately on our population that was accessing any kind of service. So the board decided at that time to make sure that anybody coming in would have just a general assessment. Do you have insurance? Do you have food access to food? Transportation? Do you have a doctor? Have you been to your doctor? And then that opened up doors for us to talk about prevention screenings. Mammograms, colorectal screenings. I mean, all those, just those couple questions allowed us to have this holistic view of this person that was coming in, maybe for a well test.
Right. Do you have any disease registries or patient registries?
Yep. So our disease registry is the Iowa Disease Surveillance System. We're required to have that from the state. We have 5 or 6 people that have had the basic epi and then the advanced epi that does all the infectious disease follow-up. We take our guidance from the state, so they're fed to us, or a lot of times we'll have our own hospital will call us directly if they have somebody presenting at the emergency room with the same kind of sickness and they were all at the same kind of event. Sometimes we'll get those firsthand, not going through the ICE system, that there's something presenting at the emergency room. We get several of those calls. So.
You used the phrase earlier, foodborne outbreaks. Can you describe how you monitor those and any that have occurred, what happened, and how you addressed it?
Yeah. So we have several times we'll have citizens or residents call that they were maybe sick and they've eaten at a local establishment. We'll monitor their sickness or their symptoms, signs and symptoms, do kind of a surveillance of, was there anybody else that ate with you? Are they also sick? There's so many different GI tract illnesses. Before we go in and say, absolutely, this was this restaurant, we want to make sure that we have the appropriate facts. A lot of times we'll monitor, we may do our own screening through a fecal matter or whichever we have to do to collect the specimen. It may be a nasopharyngeal, depending on what's going on with the symptoms. Send those in either to our local lab or to the state hygienic lab. Kind of depends on what's happening. It's case by case, and then kind of work backwards. So if there was no indication of a rhinovirus or norovirus or anything else that, well, not rhino but maybe noro, that would indicate that we have a huge problem, we just kind of deal with that within the department. So that's how we know when there's a bigger trigger. I mean, we know when there's something that is bigger than just an isolated incident. We had a wedding a few weeks ago that several people were sick and showing up at the emergency room, so we were very clear on there was something within that, in that party, or something happened, and so we worked backwards with that with the state's help. So
just kind of wrapping up the discussion about data, can you describe any challenges to managing or analyzing or reporting from the various databases we've discussed?
So we have, there's a lot of challenges right now with, I'm sure, lots of public health agencies. We have a lot of this raw data, but our time is so limited that we don't have a designated person that can really analyze the trends, analyze the data that is coming in, looking at peaks and valleys, and looking when does it spike. Is it temperamental, temperature related, or is it is there a different indicator of why it's spiking? A lot of times that falls on either myself or my epi team to look at that, and there's so many other things that are happening within the health department that we don't have that one person strictly designated to do those kind of data analytics. Another challenge that just kind of was brought to my attention earlier this week was a lot of times we're asked our opinion around health indicators. So for instance, around the contained animal food operations right now, that's a huge issue within Webster County, and so we've been receiving lots of emails and some telephone calls around what are the health indicators around CAFOs, and so that will be my challenge now to really link, if there is a linkage, probably do some research and try to figure out who's done this research. 10, 15 years ago, they weren't as prevalent as they are right now. What's happening with the runoff, what's happening with the manure management. So those are things, and again, they all take time, and a lot of times in a public health agency, what I plan to do today is not what happens. And as all our staff get pulled several different ways for the duties of the day. So those are probably the biggest ones, is that data analytical person. We have so much raw data that somebody to organize it on our behalf, or that we don't have to push it to somebody else to organize it, because we really need that person in-house to do real time. So that would be one of our biggest barriers, I would say.
Do you have ongoing routine reports? I'll put the CFO and maybe an outbreak and an ad hoc or a special study. You need to gather data real quick and come to some conclusions and recommendations. Mm-hmm. What kind of routine reports do you bring to the Board of Health?
So we do, obvious budgetary, we do performance measures, we do programmatic reports that will report to our Board of Health how we're doing on state-based indicators. So last year we were at 75%, now we're at 80%, showing the increase or the decrease, and then giving a justification around why there was an increase or a decrease, either good or bad. We will provide EPI is always reported at our boards of health so that they know what's going on. We had a crypto outbreak several years ago that they were very much in tune, wanting to know what was going on. It involved some of our swimming pools. We do quarterly programmatic numbers as well, so like around our WIC, around our child health, around sexually transmitted diseases, teen pregnancy rate, vital statistics. We pull annually through our strategic plan demographic, what's the shift in our gender, or what's the shift in our age, is there something new within our agriculture, is there a new enterprise going up or an establishment that is going to be more of a barrier on our public health system because of the types of jobs that are available to the people of these industries. So there's, we're asked to provide a lot of indicators of like what happens if. So one of the biggest ones we had was around an industry that wanted to come in that brought in several maybe migrant workers, and what does that do to our public health system. And it's going to be a large operation, and where it might sound wonderful financially in one aspect could have a negative effect in another aspect. So we're often asked to analyze those kinds of requests. It's been really enlightening that our city government now understands what our vision and our mission is within the department and seeks our opinion more often. Of course, our supervisors are always seeking opinion. Somebody made the comment the other day, if the health department doesn't have a statistic, then the statistic isn't valid in our area. And right or wrong, we want to make sure that we stay that reputable, trustworthy source of providing factual information. So you asked, what is our data collection? Again, we pull in a lot of information around the China HIP. We ask public opinion, public feedback. We go into businesses and ask opinions face to face. We deal with our law enforcement. We ask about jail diversion and jail rates. We talk to nursing homes. We talk to we have a very close relationship with our emergency room. Who's coming in? Why are they coming into the emergency room? Is there something that we can help to defer those unnecessary visits? We have a strong connection with our hospital discharge planners. Is there something public health can do out in the community to make sure that the people do not get readmitted? So those are all those facts that we're trying to collect to really give a broad range of really what's going on in our community. We use the county health rankings. I mean, those are the ones that I listed earlier, so vital statistics.
You just joined the SIM grant.
Yes.
Can you describe what you propose to accomplish?
So we collectively is the public health agency along with the healthcare system within this 8-county region. So the bottom vision of that was braiding the public health services along with the hospital vision of, reducing readmissions, reducing unnecessary emergency room visits. We all realized early that the hospital has one vision around readmissions and high utilization, but they can only go so far. They really needed a community-based entity that focused on population health to make a dent in providing education and resources around those unnecessary emergency room visits, whether it's because somebody's presenting because they're hungry or whatever the situation is. Being part of the SIM has really opened up that communication because finally the healthcare system and the public health is on the same track to try tracking the same mechanisms. So we have indicators in our office, same indicators that the hospital uses, and not only Webster County, but in all 8 counties. So we're trying to coordinate all of these standardized forms, standardized structure, standardized programming, standardized everything. So we can be a liaison to that doctor to say, just call us and we'll take care of it. And so the SIM has been a really wonderful opportunity. The big things that they're looking at collecting data on is around BMI, tobacco usage, A1C, and there's some categories around rising risk A1Cs, and then the high out of control A1Cs, and then let's see, did I say tobacco use? Yeah, tobacco, A1C, BMI, and then social determinants of health is the last one. So,
can you describe social determinants of health? That's a very big topic.
Sure. So our SIM project does this holistic approach, doing screening for insurances, where people fall in the federally poverty level, transportation, translation, any barrier that's going on in their home or wherever they live in the community to why they are not able to get to their doctor or get to their dentist or get to those providers that are providing them care. Is it an income barrier? Is it my pharmacy is across the county and I can't get to them? Is it I can't afford my medications? And so we're a handoff from the physician to address all of those circumstances that are outside the medical realm to assist the patient to live a healthier life and get connected to the resources that they need. And it's been really wonderful because we've had some really great stories around, one instance was a man needed Lovenox injection and he couldn't get it at the pharmacy because the pharmacy didn't have his insurance. So his provider was telling him you need to get admitted to the hospital because Lovenox is a DVT, so you need to get this injection, and if you can't get it there, you need to be hospitalized to get the injection. Well, the provider, this was just at the beginning of this SIM meeting, called us and said, did we have any avenue to get this man a Lovenox? So we worked backwards. Well, the insurance was just off one number. So we coordinated with the man to get the insurance, got the Lovenox injection. This is Friday at, of course, 5 o'clock. Worked with the provider to order us just to go in for 5 days and give him the Lovenox injection and education. So it cost our agency $700 to send a nurse to go give him the Lovenox injection and education, and have a 24/7 on-call person that he could call on a Saturday, versus, you know, $12,000 for a 5-day admission into the emergency room on something that was so preventable. And so, yeah, I mean, there's doing this work now, there's just so many stories, and the really cool thing is it's not just us realizing that, it's this healthcare is, you know, slowly and surely, you know, understanding that it really is this community-based vision of population health. They're not quite there yet, but they'll get there.
Anything else you would say to the public health community, or to the SIM community, or to the University of Iowa students?
So the public health community, stay strong, get to the table. We do amazing work. A lot of times people don't understand the work that we do, that we're behind the scenes. Give yourself the credit that you do. We really do phenomenal work in the communities. To the SIM communities, this work is so important. If we want to reduce our healthcare cost, it's going to take boots on the ground, grassroots level, and these SIM communities can do it. To the public health college, we're always looking for students, or if you want to shadow, we are always willing to open the door and let you learn about, you know, not only just what we do, but I'm sure there's other public health agencies that would love to show you their services and their protocols and their policies and what they actually do. So.
Excellent. Anything else on your mind?
I don't think so.
Nicely done.
Thank you.
Push a button.